All right, hello everybody. Kathy does send her apologies that she can't be here, so I will do my best to cover all the things that she was going to talk about as well. So I'm the National Education Manager at Kidney Health Australia. I look after the teams that do our health professional education, so for nurses and GPs, and also all of our consumer education. So there are a few bits and pieces I've popped on the table that will relate to the information in the talk today, so if you're interested in taking them with you, please do. I prefer not to lug them all back to Adelaide in my suitcase. So the talk today is about hypertension and chronic kidney disease. And first of all, what we'd like to cover is basically understanding the link between hypertension, cardiovascular disease and chronic kidney disease, have a bit of a discussion around the impact of some new and emerging evidence on primary healthcare nursing practice, and then talk about implementing a framework for best management of clients, including lifestyle and pharmacological management, and we're going to do that through a case study to keep it a bit more interesting. So first of all, what is chronic kidney disease? The way we define chronic kidney disease is sort of twofold. So first of all, if there's a GFR of less than 60 and it's present for over 3 months with or without kidney damage, then we say that that's chronic kidney disease. Or if there's evidence of kidney damage, so that can be albuminuria in the urine, hematuria after exclusion of urological causes, pathological abnormalities, so that might mean that they see some casts under the microscope or something if they're looking at things, or anatomical abnormalities, so that might be they see some scarring on an ultrasound or something like that. So sort of the twofold thing, you can have a reduced EGFR, or you can have a normal EGFR but have evidence of kidney damage, and both of those things are chronic kidney disease, and for it to be chronic, like everything else in practice, it needs to be present for 3 months or more. In Australia, chronic kidney disease is a major health problem. 1 in 10 Australian adults will have signs of chronic kidney disease. Research that's come out in the last couple of years shows that of all the people out there with CKD, less than 10% are aware that they have the condition. So that's, why we sort of exist, is to try and get people to start having discussions about CKD so that hopefully that number improves. Part of the reason that many people don't know they have it is because you can lose up to 90% of your kidney function before you experience any symptoms. So most people will feel quite well up until the point where they're about ready to need dialysis. So that's why it's really important to be screening for kidney disease in practice when you're seeing people who are at risk. And then one of the major things is that chronic kidney disease is also an independent risk factor for cardiovascular disease. So for people who have CKD, they're 20 times more likely to die of a cardiovascular event than they are to survive to the point where they need dialysis or a transplant. So dialysis and transplant is really just the tip of the iceberg, and there's all these other people out in practice who will also be kidneys will also be affected. So when we talk about risk factors, we've got both modifiable and non-modifiable risk factors for kidney disease. So risk factors that unfortunately you can't do anything about is being aged over 60. If you have a family history of kidney failure, so that might be a parent or an uncle or a sibling who has needed dialysis or transplant. If you've had a previous heart attack or a stroke, you're of Aboriginal or Torres Strait Islander origin, or you've had a previous acute kidney injury, so that often happens in people who've played a lot of sport and things like that. They may have had a kidney injury playing footy or something earlier in their life, then that does put them at increased risk of developing chronic kidney disease. Risk factors that people can do something about is having diabetes, high blood pressure, being overweight or smoking. So they're all things that something can be done about. So the recommendations for screening in practice is to do a kidney health check. So there's 3 components to a kidney health check. The first one is your blood test for EGFR, and that's the way they work out EGFR in Australia. It's automatically reported on your pathology reports, but they use an equation to convert it from the serum creatinine. So if you hear people talk about creatinine, that's what they're actually testing for, and then they use an equation to convert it to EGFR, and both should appear on a pathology report. Then the second part of the kidney health check is a urine test, and that's for an albumin and creatinine ratio. In the past, people have used dipsticks a lot to test the urine. We don't actually recommend that anymore because they can tend to miss people with kidney disease. So dipsticks pick up your big proteinuria molecules, which will start appearing once you've got quite a lot of kidney damage. Albumin molecules are a lot smaller, and so they show up earlier in kidney disease. So by doing an ACR, those people are getting picked up, whereas if you just did a dipstick, it might say that they didn't have protein in their urine when they actually do. They just don't have enough for it to be picked up on a dipstick. So that's the reason that we don't recommend doing the dipsticks anymore. And the third part is the blood pressure check. So blood pressure and kidney disease are quite closely sort of integrated, and it's very important to think about the two together. So when we come to link kidney disease with diabetes and cardiovascular disease, they really are a cluster of closely related conditions, and they account for about 2/3 of all deaths in Australia. So we would really encourage you guys, when you're seeing people in your practice with diabetes or with hypertension or cardiovascular disease, to be thinking about kidneys as well. It is a simple check to check people's kidneys. And so then I've just popped a case study in here to sort of highlight some of this, and then how some of the newer information that's come out with hypertension and things can relate to practice. So I've popped in the case study of Margaret. So Margaret's 56 years old. She's a secretary who's working full-time. She's married with 3 adult children, and she's one of 3 siblings, and her siblings are all fairly fit and well, no major health concerns. And Margaret's just attended the surgery for a flu vaccination and a bit of a checkup as well, as she does yearly. So a bit more history on Margaret. Margaret is a female Caucasian background. She's 98 kilograms, which gives her a BMI of 38. So she's in the obese weight category. Her weight circumference is 120 centimetres. Her mother had type 2 diabetes, and her father died 8 years ago following a heart attack, and she thinks he had some kind of kidney problems, but wasn't on dialysis or anything like that. Margaret's also a smoker. She smokes 1 packet per week, which would give her a 9-pack year history. So when we talk about pack year histories, that's 1 pack of cigarettes a day, every day for 9 years. That's how you work out pack year history. She drinks a bit of alcohol, about 3 glasses of wine on probably 4 to 5 days of the week, so she's not drinking every day. Doesn't really do any regular exercise, has a history of hypertension, is not on any regular medications, and also takes non-steroidal anti-inflammatories for back pain following a car accident that she was in 12 years ago. So, is Margaret at increased risk of CKD? What do you guys think? Yeah? Does anyone want to venture why you think she might be at risk? Yeah. So she's got at least 3 of the 9 risk factors for kidney disease. We know she's got hypertension, we know she's obese, and we know she's a smoker. She could possibly have a few of those other ones as well that we don't know about. So I think that's enough risk factors to warrant doing something about it. If we look at what the main causes of kidney disease are in Australia, diabetes is the leading cause. About just under 40% of kidney disease is caused by diabetes. If you look at an Indigenous population, that figure goes up to closer to 60% of kidney disease being caused by diabetes. Blood pressure, you can see, is about 13%, so it's still quite a large slice of the pie when it comes to causes for chronic kidney disease. So high blood pressure can damage the small blood vessels in the kidneys, and the damaged vessels then cannot filter the waste products from the blood normally. Or another way of sort of saying it is basically that kidneys can cause high blood pressure, and high blood pressure damages the kidneys, so it's sort of a bit of a cycle. Unfortunately, they usually go hand in hand, and people will often have both kidney disease and hypertension. If we're looking at sort of what difference adequate blood pressure management makes on the progression of kidney disease, you can see Margaret's over here. Let's say her blood pressure is 160 on 95. you can sort of see that that equates to a MAP reading, which is just what they used in this study of 116. But that equates to losing over about more than 10 mils of GFR a year. So when we talk about GFR, if someone's got a GFR of, say, 60, that's roughly equivalent to having about 60% kidney function. So if she's losing about 10 mils a year in GFR, that's about 10% of her kidney function a year. And then you can have a look up here. If you're able to lower her blood pressure to, say, 130 on 85, then that decline in her kidney function would really slow down to about 3% of her kidney function a year. So adequate blood pressure treatment really can make quite a difference in people's outcomes in kidney disease. In terms of what the target blood pressure targets are for people with kidney disease, this is an area where there's a lot of research coming out. Currently, if someone has albuminuria, their blood pressure should be below 130 on 80, which is the same if they have diabetes. If they've just got chronic kidney disease and they don't have albuminuria and they don't have diabetes, then the target is slightly higher, 140 on 90. There is quite a bit of new evidence that's come out in the last 2 to 3 years around blood pressure targets. There was a big study called the SPRINT study that was published in 2015 that looked at aiming for lower blood pressure targets in people down to about 120 on 80 they were looking at. And it was looking at people at high risk of cardiovascular events, which included CKD patients, but wasn't specifically looking at kidney patients. Basically, the study showed a reduction in cardiovascular events and all-cause mortality by aiming for a lower blood pressure target without affecting their kidney function measures. However, we did see that there was an increased incidence of some adverse events, including falls and acute kidney injury. So you kind of need to balance what target you're aiming for based on the person in front of you. So if they're likely to be higher risk for falls or an acute kidney injury anyway, you probably wouldn't want to aim for that lower target. But if they're a young, fit, healthy person who happens to have kidney disease but otherwise don't have too many other comorbidities, then it's probably appropriate to aim for a lower target, because the studies have shown that there can be some good outcomes. So we saw that in 2016 the National Heart Foundation changed their guidelines to recommend lower targets for people. Kidney Health Australia at the moment has kept our guidelines consistent with the National Vascular Disease Prevention Alliance, or the NVDPA. We are redoing our guidelines later this year, so this is something that we'll be looking at then. So we may change our recommendations around the targets a bit later in the year, but at the moment the targets on the previous slide is what's in our guidelines, so that's what we would advocate that you can safely aim for. And if you've got someone who you think it's appropriate, then you may choose to aim for a lower target. Back to Margaret. So Margaret has 3 to 4 of the risk factors for CKD. Does anybody want to have a go at saying what to do now? Yeah, so Margaret should have a kidney health check, and she should have it every 12 months. So for people with diabetes or hypertension, they should be having this test every 12 months. To move from having a positive kidney health check result, so say it comes back and her results indicate that she's got kidney disease, you need to repeat the test you need to have 2 out of 3 tests being positive, and it needs to be that way for a period of 3 months or more. So it's a good idea to add Margaret to your recall and reminder list for a 12 monthly follow-up, and also flag with the GP if they need to be involved in ordering the tests. And it's also a good time that you can have a look at some of the resources and things, and maybe utilise the kidney helpline if Margaret needs additional information on kidney disease. So we operate a kidney helpline at Kidney Health Australia, which is a free call service that you can refer people to. It's staffed by a renal nurse, so she can answer She doesn't answer specific medical questions to the person, but she provides general information around kidney disease, and she'll also send them out free resources, so it's a really good way if you think that they could use a book or something like that about kidney disease or some fact sheets and things. She'll send all of that out to them for free. A good resource for people who are newly diagnosed with kidney disease is the My Kidneys, My Health Handbook and app. It's again a free resource. There's a little bit on your table if you're interested in getting it for people, but it talks about self-management and what is kidney disease and aims to answer lots of the questions that people may have when they're first diagnosed with kidney disease. So Margaret's results have come back. Her EGFR result is 55, her urine ACR test result was 5.7, and her blood pressure was 155 on 95. So they certainly indicate that she would have CKD, and if you did those tests again and the results were repeated, this is where she would fit on the staging table. So you can see an EGFR of 55 falls into this 3A category for EGFR, and she's got some microalbuminuria because her level was 5.7, so that puts her here, which is in the stage 3A with microalbuminuria category for kidney disease. And the table's colour-coded, so you can then follow what we call the orange clinical action plan for kidney disease. And where you find those colour-coded action plans is basically in the Guidelines Handbook, which is this book here, and there's a flyer on the table that can tell you if you need to get a copy of the guidelines, where you can get it from. And we've also got the Guidelines app, which is called CKD Go. It's free to download in the various app stores. So that's where you can get the action plans that tell you what the goals of management are for that stage of CKD, what steps you would need to do, and it's got some extra information around managing hypertension in CKD in that book as well. So in terms of what you could do in reducing Margaret's risk of cardiovascular disease, you guys probably already know all of this stuff, and you're probably doing most of it in your practice for other conditions, so it's more rather than me standing up here saying this is what you need to do, probably just a reminder that when you're doing things like lifestyle modification, perhaps for conditions like diabetes and that, then it's also really relevant to people with kidney disease. In terms of lifestyle modification effects on blood pressure, there's some, it can actually make quite a big difference. So weight reduction can reduce it by about 4.4 milligrams of mercury. Dietary sodium restriction 4 to 7, a DASH diet, so that's the dietary approaches to stop hypertension diet, 5.5 to 11.4, physical activity by about 5 as well, and reducing alcohol consumption down can make a bit of a difference as well. All those things aren't completely cumulative, so if you did every single one of them, you're not going to reduce the blood pressure by 30 milligrams of mercury or something just by doing them, but they will certainly make a difference. In terms of physical activity recommendations, again, just to sort of recap what I'm sure you probably already know from your practice, moderate intensity activity 5 days a week, 30 to 60 minutes a day, or strength training for 3 days a week, or vigorous intensity activity, which is probably a smaller portion of people doing that 3 days a week. My husband's probably one that does the vigorous activity. I'm probably more on the moderate end. And yeah, if you're wanting there's lots of also diet and nutrition resources and things on the Kidney Health Australia website if you do need specific diet or lifestyle recommendations for people with kidney disease. That's all there, as well as fact sheets on blood pressure and kidney disease. Basically just a few points on managing blood pressures for people with kidney disease. So as I said before, CKD can cause and aggravate hypertension, and hypertension contributes to the progression of CKD. Maintaining blood pressure targets below the target level is really important for the management of CKD, and you saw on that graph before how if you can reduce the blood pressure down, it can really delay the progression of chronic kidney disease, which means the likelihood of someone needing to have dialysis or a transplant is a long way down the track instead of maybe a few years down the track. We recommend either ACE inhibitor or ARB therapy, so recommended first line. We don't advocate using the two agents together, it's one or the other. And often maximal tolerated doses of ACE inhibitor or ARB are recommended. If hypertension is really difficult to control and people are on, say, 3 or 4 different medications for hypertension, which can be pretty common in kidney disease patients, that's the stage where they would usually go and see a nephrologist. So that's one of the referral requirements, and in the handbook it lists out all the criteria for referring to a nephrologist as well, and who should and shouldn't be referred. So just in summary, kidney disease is really common. It is harmful, but it is also treatable. Hypertension is a major risk factor for chronic kidney disease, and early detection of kidney disease is really beneficial for people's outcomes. You guys can identify people at risk in your practice and perform a kidney health check annually on people with hypertension or people with diabetes. If they have the other risk factors and not hypertension or diabetes, it's once every 2 years is sufficient. Blood pressure should be maintained consistently below the relevant threshold. Individualising blood pressure targets is really important, particularly given the new recommendations that are sort of starting to come out that you can aim for lower blood pressure. If there's one sort of key message, I'd keep that in mind, that you really need to think about the person in front of you and when you're picking what target to aim for. And lifestyle intervention, the DASH diet, physical activity is important for outcomes. And most CKD patients can be managed in general practice. Most people don't need to be referred to a nephrologist. And if you look at the goals of management and things in the handbook, you'll see that most of the stuff that's in there can be done in general practice. So all of this basically has the potential to halve the number of patients presenting with kidney failure if we can pick them up early in general practice. So thank you, that's my talk.